Welcome to ATCM, the Emergency Medicine Channel. It's a case of 16-year-old boy came to ER with alleged history of drowning in fresh water approximately 10 minutes prior to arrival of ER. Initial bystander also given a history of attempted CPR at the site of presentation.
This patient was drowning and was brought in with ongoing CPR. So how much time he was in water immediately?
Approximately 5 minutes. That's what bystander given history, that they don't know how much minute.
Is there any significance with the time?
Yes, ma'am. So the time and duration of submersion determines the outcome of the patient. If it is more than 10 minutes, outcome will be bad.
Okay. So in this case, is there any difference in management with the time duration in which the patient was struggling?
Yes, ma'am. Duration of submersion is the main factor that determines the outcome. Poor prognosis if the duration is more than 5 minutes, and the time of effect of BLS or base of more than 10 minutes. Resuscitation duration of more than 25 minutes. Age more than 14 years. JCS less than 5 at the time of presentation. If the patient is in persistent apnea or requirement of CPR in ER, and if the pH at presentation is less than 7.5 at the poor prognosis in patients who are given history of drowning.
Okay.
So absence of spontaneous or purposeful movement after 4 hours also gives an ominous sign.
Okay, so suppose we have do you know the chain of survival in case of drowning?
Drowning, hypoxia.
No, chain of survival. We say the chain of survival in case of ACLS, PALS and all. No. So basically, when individual, first thing is chain of survival is prevention. As we say for ACLS, always prevention. Prevention in case of adult cardiac arrest and pediatric cardiac arrest, we say first in hospital is prevention. So in a drowning scenario, prevention is preventing by wearing a life jacket or wearing a floating tube or something. So first step is prevention. Then next step is recognition. As we say for ACLS itself, first prevent, then recognition. So recognize. So if somebody is swimming in the water, we won't be recognizing. So if at all we see a individual who is struggling in water, then we will have to recognize that. And what is the third step? Call for help. More than calling for help, if at all if we are in a scenario that we are not in a position to call anyone for help, nobody else is around. So what will you do? Will you jump into the water?
No, scene safety.
We need to check our scene safety. That is correct. So if at all it is possible, we don't know what kind of water that is. If it is like a stagnant water and all, there is better chance of survival. Whereas it is a flowing water and all, the rescuer itself will be in trouble. So if we don't know swimming, even though we know swimming, in that scenario it will be difficult to rescue an individual. So if at all we know or we don't know swimming, the better way is either to give a rope or a floaty to that individual so that that individual can float for some time. So if possible, we can give a long shawl or a long cloth, or if at all not possible, a coconut branch or something to that individual can hold on to that and come out. So that is one thing. So third thing is so first thing is prevention. Second thing is identification. Third thing is giving something to the individual. Then fourth is trying to bring the patient out. If at all we are giving some floaty or anything, rescue from that water. And next is management process. Okay. So if at all you took this individual out of the water, when will you plan on giving rescue breaths?
As soon as possible. Most common cause of drowning, like respiratory arrest, if the patient is there, is due to hypoxia. So first thing we have to give is rescue breath.
So especially in the drowning is more than 5 minutes, we will have to give rescue breaths. We will have to take out of the water and give rescue breaths. Okay.
Then start CPR if the patient is having signs of cardiac arrest.
Okay.
Then according to BLS we have to follow, and when the patient came to ER, we'll shift to ACLS protocol.
Okay.
So in our case, initial 10-second assessment, breathing was absent, so we given bag and mask ventilation, and later a patient we intubated the patient and started on ambu bags. Then airway, since it's secured with the AT tube, and while intubating, laryngeal edema was there
Okay,
with
so
the succussion.
so why the patient is having this airway? What all are the problems of drowning?
Most common problem is hypoxia. Most common.
Why this hypoxia is happening?
Then CO2 level, like patient not able to like sink in submerged in water. CO2.
Do we use the term dry drowning, wet drowning, and all?
No.
It is
No,
not used because such terminologies are not there. What was it actually?
Dry drowning is when patient, if it is a cold water, it's a sudden closing of laryngeal cord, and patient will die due to asphyxia.
Vocal cord spasm.
Okay. And wet drowning is when water gets into the lungs, causing pulmonary edema, ARDS, and then
death. Okay. So what all things? So most commonly, what happens is a problem with the breathing will happen. So what all things will happen when we drown to the water?
CO2 level will be decreased.
No. How?
Like not able to breathe. So air and secretions, water can go into the lungs. It can irritate laryngeal cord, can cause laryngeal edema.
Laryngeal edema can happen.
Or it can go into the lungs, causing non-cardiogenic pulmonary edema that can lead to ARDS. And then in cardiovascular system, this arrhythmias, cardiac dysarrhythmias can occur, such as polymorphic VT or bradycardia, then can go into arrest. Then electrolyte imbalance can occur.
Okay, so when mainly I was talking about the breathing part. So when the patient is in the water, what will happen, because as the water enters inside, there, as you told, there will be laryngeal spasm, pulmonary edema, all these things will happen, and the surfactant will be destroyed. So because of that, all the alveoli will come and get collapsed. So that will happen. So hypoxia is there, and because of the alveolar collapse, hypercapnia will be there. So patient will go in for hypoxia induced lactic acidosis, and carbon dioxide PCO2 retention will happen, and respiratory acidosis will also happen. So what is the endpoint of acidosis? Acidosis can in turn cause hypothermia. Usually our part in India and all, especially in South Indian region, the water is not that cold to cause a hypothermia. Usually hypothermia will happen if the temperature is less than 5 degrees Celsius. So but still we get cases of hypothermia because of the acidosis causing hypothermia, coagulopathy, all these things will happen. Okay. So this individual came in cardiac arrest. Okay, so any specification for drowning cardiac arrest?
Most common cause is respiratory arrest that can lead to bradycardia and cardiac arrest. So this they can more PAs will be more like pulseless electrical activity is more, but in case of cold drowning, dysarrhythmias can also cause such as VTs.
Okay, so when we are resuscitating the individual from the water, what is the role for when all will you plan on stabilizing the C-spine?
If the history giving a diving injury, according to ATLS, we can stabilize the C-spine using C-collar, but if the history is suggestive of any diving injury or patient having focal neurological deficits, or we are suspecting injury in the neck, we can put a C-collar and stabilize the C-spine.
By the mechanism?
Head first hit.
Okay, diving you told. Other than that, if it was secondary to an RTA falling from the bridge like that, or if this event occurred secondary to a seizure or something, as some mechanical cause which is leading to the drowning, then we'll have to suspect C-spine injury, and we'll have to stabilize the C-spine. So this individual was brought to us. This individual was in cardiac arrest. Is there any significance in how much time will you check for the pulse?
Hypothermia can cause bradycardia, so more than 10 seconds we have to check for the pulse.
Okay, so in a drowning case, we need to suspect hypothermic cardiac arrest, so we need to have a prolonged pulse check. That is important, and we are suspecting more injuries and issues to the airway, so we'll have to plan on a early intubation also. Okay, so we have started
CPR.
high quality CPR was started.
Intubated the patient, C-spine was stabilized with the Philadelphia collar. Since we don't know the mechanism of mechanism of jump, then
Temperature, what was the temperature?
Temperature was normal, ma'am. Peripheries are also warm. Like core temperature was normal only. So, but still we prevented hypothermia, like further hypothermia by giving blankets and warm saline.
First, we need to wipe the
off,
patient. Then that is the first passive rewarming. We need to wipe the patient, and then only we need to plan on rewarming, giving warm blankets, bear huggers, and all. Okay, so if this patient was in hypothermia, how will you manage?
First, as you ma'am told, we will remove every clothes. Then we start on a passive or active external rewarming, like warm blankets, then hot saline, bear hugs. Then if ROSC is attained, then
No, cardiac arrest management.
Cardiac arrest, then we'll then
I am asking difference between adult cardiac arrest, normal cardiac arrest, and a hypothermic cardiac arrest. Pulse check should be prolonged. Early intubation should be considered. Then
shocks, 3 shocks.
Maximum 3 shocks up to how much temperature? Up to the core body temperature becomes 30 degrees Celsius. Up to 30 degrees Celsius, we need to give only maximum shocks. When adrenaline
also, if it temperature is more than 30 we can give.
Okay, more than 30 degree, we will plan giving adrenaline. How much adrenaline?
half the dose.
No,
dose is in interval is
interval. So temperature is between just above 30 degree. We will give adrenaline same dose itself, 1 mg, 1:1000 dilution. But we need to increase the gap. After 6 to 10 minutes only, we are supposed to repeat. Till how much degrees? Till 33 degrees. After 33 degrees, we can give adrenaline as per normal ACLS protocol. Okay.
Then
So this patient was not in hypothermia.
and the cardiac arrest duration was
Duration resuscitation also
prolonged
should be
resuscitation.
prolonged till the patient's core body temperature becomes
become
normal.
normal.
Okay, so this patient was not in hypothermia. We are suspecting a hypoxic cardiac arrest. Okay. So we have started resuscitation. We have intubated the individual. Okay. What?
Then CPR was continued.
And breath was given every 5
seconds. And since temperature is normal, we were giving norad at a normal, like
Noradrenaline.
I mean adrenaline every 3 to 4 minutes. Then in between patient also when have a polymorphic VT, we shock the patient and try to revive the patient.
So what all specific things we need to check before shocking the patient?
Every clean the body, no wet patches, and then
Okay.
water, conductibility
Should be considered.
considered.
Okay. What all 5Hs and 5Ts did you consider in this point of time? What was ABG finding?
ABG showing metabolic acidosis, ma'am, with a 6.9 and bicarb of 18 with a lactate of 12.
Okay.
Then potassium was normal only, but since potassium is 3.4 normal, rest everything like metabolic acidosis due to lactate. Rest everything was within normal only.
Okay. So
Fine.
what are the reversible cause of cardiac arrest in case of a drowning individual? One is
Hypoxia.
Then
Hypothermia. Acidosis.
hypothermia.
Hypothermia.
Then
Acidosis.
hyperkalemia is unlikely.
dilution,
Hypothermia.
Hypokalemia.
hypokalemia,
Hypotension can happen.
Tension.
Hypotension can happen. Then any T's.
Toxins.
If
Bad
this was secondary to a toxin
Toxins.
ingestion, we need to suspect toxins
Toxins.
also. Then if the fall was secondary to
an
a MI, like a syncope secondary to an MI cause, then we'll have to suspect cardiac thrombus.
Then secondary to accident, we can suspect pneumothorax. Then tamponade can also, if it is
That is secondary to RT.
active.
Okay.
This patient like always hypoxia, acidosis.
Okay, okay.
Yeah.
Okay.
Rest everything. We did an E-fast also. It just came to be negative only.
Okay.
ECG, since we tried to resuscitate, only ROSC was not attained. So ECG was still.
So how many minutes did you try resuscitation?
We did a prolonged resuscitation up to 1.5 hours.
Oh.
Still, we didn't get him. It's a very young individual.
So what is the minimum time in which you try resuscitating a patient in hypothermia or drowning?
More than 20 minutes, like minimum of more
Minimum
than
40
minutes.
40 minutes.
This prolonged resuscitation is effective if there is no acidosis. Then they drowned in cold water, like hypothermia proceeding to asphyxia. Then this will be effective due to this cardiac brain neuroprotective due to hypothermia. Effective prolonged resuscitation with a less neurological morbidity mortality. Even after prolonged resuscitation, we didn't.
ROC was not attained.
ROSC was not attained.
Okay, so how will you manage a drowning case otherwise?
Otherwise, if patient is in cardiac arrest, we'll manage according to cardiac arrest management with the temperature, like core temperature, to be kept below. And if the ROSC was attained post cardiac arrest, we if it is normothermic patient, we prevent hypothermia. If it is hypothermic and also permissive hypothermia can be kept between 33 to 36. Then hypothermic patient will make the patient temperature more than 33 degrees Celsius. If it is a refusing rhythm, we'll manage ABC, then cervical immobilization, then SpO2, EtCO2, continuous core temperature should be checked. With if it is bronchospasm or anything, we'll manage it accordingly. Initial testings include ECG, X-ray, electrolytes, ethanol. If it is consumed ethanol or barbiturates, we can check serum levels. In case of management, we have to manage the hypoxia, which is by first oxygen ventilation and keep the O2 level more than 95% SpO2, and also PaO2 of more than 60. If NIV, then first O2 it is not maintaining, we can start on non-invasive ventilation. Still not there, we can start on ET, invasive endotracheal intubation.
What are the indications of intubation in case of drowning?
Signs of indications include signs of deterioration of neurological status or inability to protect the airway, and if inability to maintain PO2 of more than 60 and SpO2 of more than 90, even using NIV, and evidence of ventilator failure with worsening of respiratory acidosis
And cardiac
arrest. Then NG tube or nasogastric tube can be put to relieve the abdominal distension if water is there. Post-depressive ventilation is one we have to keep. In ventilator, we have to keep a high PEEP with a low tidal volume and avoid permissive hypercapnia. Then bronchoscopy and everything can be done if we suspect aspiration of foreign body. There's if it is possible, we can start on ECMO, extracorpuscular membrane oxygenation for refractory hypoxia, if the center is provided with that. Candidates for ECMO, candidates include not severe acidosis, that is pH less than 7 is not a candidate. pH should be more than 7, and no prolonged cardiac arrest, and organ failure should not be there. That is example renal failure, creat should be less than 1.5. We can consider ECMO if center is providing that. Then after ROSC attainment, we have to if the patient was submerged in a grossly contaminated water, we can give antibiotic coverage to prevent pneumonia. Then hypotension should be correct.
Antibiotic and depending on the type of water, subtypes we'll have to get anaerobic coverage, fungal coverage also.
Then
so suppose the patient has a hypertension, how will you give fluids?
like IV crystalloids should be given. After assessing the IVC, we can give fluids. Normal, like 20 ml per kg.
What type of fluid can be given?
Warm, if hypothermia, warm fluids. Otherwise, IV.
We are supposed to avoid hypotonic
Hypotonic.
fluid. Isotonic fluid should be given. Normal saline like that should be given. Okay.
Then if still hypertension persists, we can start him on noradrenaline supports. And we have to persistent hypotension can be should be an indicator for cardiomyopathy or decreased cardiac output and high pulmonary vascular resistance, like if hypothermia can lead to. So echo, pulmonary artery catheterization or EFAS can also should be done to, if hypotension is there, to rule out any other pathologies. Then hypothermia should be prevented, and persistent altered mental status we have to look for continuous. If the patient is in a coma, we have to do a EEG to rule out a non-convulsive seizure episodes, seizure activities. And to prevent secondary neurological injuries due to ongoing ischemia, that hypoxic ischemia can occur due to prolonged hypoxia. We have to prevent cardiac cerebral edema, hypoxia, and everything can cause secondary neurological damage. It should be prevented by avoiding hypoxia, hypercapnia, hypotension, pain, and urinary retention, agitation, anything that can increase the ICP. We have to prevent that. We have to end elevation should be kept, and if administration of hypertonic saline or mannitol is also permissible. In case of deposition of the patient from the ER, if the patient is asymptomatic, that is, there is not even a cough after drowning, and immediately rescued. If no respiratory signs or patient can able to recollect every event and normal O2, normal vital, we can dispose the patient and ask them to come to ER if any respiratory, if any breathing difficulty or respiratory symptoms develop. But in case of symptomatic patient, even if with normal O2, we have to observe him for minimum 8 hours. It is said that any respiratory component, any complication can be developed within 8 hours. So only discharge the patient if there is if patient is having a normal mentation, no new or worsening condition, cough, if the patient have cough which is improved, or dyspnea which is improved after observation, normal age adjusted vital signs are there, O2 requirement is not developed within the 8 hours, and normal auscultation finder, we can discharge the patient, ask them to come if any worsening of symptom. Admit the patient if there is arrest or apnea, any cardiac arrhythmias, hypoxia or abnormal X-rays or unconscious patient, we have to admit the patient and further evaluate the patient. And also children less than 5 years, greater than 5 years, or any resuscitation is done, or hypotension, altered mentation, mental status, we have to admit the patient and further evaluate
And
the
we need
patient.
to admit if it is because of any secondary causes like a seizure or a syncope or any cardiac arrhythmias or an RT if you are suspecting. How will you grade this patient? A drowning patient?
Drowning, basically non-fatal, fatal drowning.
Actually, you can grade from 0 to grade 1 to grade 6. So this individual came in cardiac arrest, so it is grade 6. So grade 1 means patient is asymptomatic with SOS, minor cough or something. Grade 2 means we are getting on auscultation, we are getting some amount of chest findings. Grade 3, we are getting entire chest findings, we are getting throughout the lung fields. Grade 4 is chest findings along with hypotension. Grade 5 respiratory arrest, grade 6 cardiac arrest. So we are allowed to discharge only grade 1 individuals. That means they don't have any chest findings. From grade 2 onwards, we will plan on admission. Okay. Anything else?